neurological examination of the lower extremities. Now this video is not a demonstration of the actual examination. That is a separate video which I have put a link to in the details below in the description. This one, similar to some of my other videos, and that for the upper extremities neurological examination, as well as your abdo cardiorespiratory exams, is a detail as to what exactly it is that we're looking for in the examination. I'll talk you through the examination and what the findings actually mean, the clinical findings, and what they actually indicate. So what pathology. So without further ado, just before we move off, I'm going to, with the end-of-bed examination, which I didn't do in the upper limb examination. Your end-of-bed examination may entail the likes of your clinical paraphernalia, so your walking aids, your walking crutches, a space boot, a wheelchair, a hoist. Medications may include the likes of lamotrigine, cocarodopa, sodium valproate. These are very commonly used medications or drugs in the neurological context here in the UK. Now, in terms of the patient themselves, so again we've got the acronym of SWIFT, so scars, wasting of the musculature, or imbalance in the musculature wasting. So atrophy is what we refer to, that's muscular atrophy. Involuntary movements in terms of such as Huntington disease or Sydenham's chorea. And then you've got fasciculations. Now fasciculations are actually a lower motor neuron lesion. These do not emanate from the CNS, the central nervous system. So fasciculations essentially are flickering of a small group of muscles, and this is due to hyperexcitability of the neuron that actually innervates them. Most common fasciculation, what most people may well have experienced or come across, is that of the upper eyelid when it flickers. Other areas of a similar sort may include the likes of your quads on the anterior aspect of your thigh. And then finally, you've got your tremor. Now, tremor may be what we call a primary idiopathic tremor. If patients are on salbutamol with regular use, they might have a salbutamol tremor. And in the context of neurological symptomology, you may well have something referred to as intention tremor, which we will again re-examine in the context of cerebellar dysfunction. So again, a separate video for the cerebellar dysfunction. And then you have the likes of a pill rolling tremor, which essentially looks like, the patient doing this. Now, in some faiths, religion, beliefs such as Islam and Hinduism, they have a bead of string of beads, and those beads they will actually use to essentially carry out some religious practices where they recite the name of their creator. As such, a number of occasions when I've seen this, I came across a particular one case that springs to mind, and the individual thought that their loved one was actually in constant remembrance of their creator, their Lord, whereas in fact this was actually a clinical indicator of Parkinsonianism. And so pill rolling tremor, indicative of Parkinsonianism, and that's different to Parkinson's disease, because Parkinsonianism essentially is a collection of symptoms which are due to effect on the basal ganglia and the putamen, etc., as compared to Parkinson's disease, which you make a definitive diagnosis of in the collection, in the situation where you've got an amalgamation of a certain set of symptoms. So Parkinson's is different to Parkinsonianism. In terms of the face, you may well look at the patient's face there. If there's asymmetry, if there's loss of the nasolabial fold, if there's partial ptosis of the upper eyelid, so your nasolabial fold, or loss of the angle of the mouth here, may be indicative of a cerebrovascular accident like a stroke. In the situation where you've got partial ptosis of the upper eyelid, that may be due to damage to the facial nerve or elements of, as well as the cranial nerve number 3, again both of which innervate parts of the superior palpebral muscles. If you've got loss of muscular tone in its entirety all the way from the forehead inclusive, that may be indicative of Bell's palsy, a lower motor neuron lesion. In the context where this forehead is spared, that again may well indicate a cerebrovascular accident, and there's a separate video on how to delineate a cerebrovascular accident from Bell's palsy. Moving on, and again, don't forget Horner syndrome is another manifestation, so you want to look at the size of the pupil and see that there's no unilateral meiosis in the situation Horner's, or otherwise a unilateral mydriasis, enlarging or dilation of the pupil, and that could be a normal variant in situations where you have, for example, Argyll-Robertson pupil, or you have Holmes-Eddy pupil, amongst others. Then we the patient themselves, in terms of are they demonstrating involuntary movements, are they writhing around, are there any symptoms of what we refer to as EPSIs, extrapyramidal side effects, such as those that might occur as a result of use of antipsychotics. These may include the likes of tardive dyskinesia, akathisia, again amongst others. So we and then finally you might look at the patient's upper extremity, lower extremities in its generalized overall, a decerrate position, a decorticate position. Do they have situations where, for example, the wrist is dropped in the context of radial nerve palsy, or if the hand is clawed in the context of ulnar nerve pathology or palsy, and if they demonstrate something to that effect, which essentially is your apostle hand in the context of median nerve palsy. So the way to remember that is Dr. Kumar, D-R-C-U-M-A, D for drop, which is radial nerve, C for claw, and therefore U for ulnar, and M for median nerve, A for apostle hand, and that's a little mnemonic there for you. Moving on to the actual lower extremities itself. So what I start off with, again, we've got sufficient exposure of the lower extremities, and the patient has all been prepped in terms of introductions and all that malarkey. We then move on to, I ask the patient to cross their hands over like so, and ask them to sit up and then stand up. And what I'm assessing here is for proximal muscle myopathy, and that may well be in this situation where you've got Cushing syndrome or other disease or other manifestations. I then ask the patient to walk, and as they walk away from me, I look at their gait. If it's a wide gait, a wide stance gait, indicative of cerebellar dysfunction. So most of this is all cerebellar dysfunction, and anything that's not, I'll point out. So wide stance gait, cerebellar dysfunction. Scissors gait, where you get basically like a catwalk, where the legs cross the midline, and that's because due to excessive tone of the adductor muscle groups on both sides, and that's indicative of cerebral palsy. Then you may well have an antalgic gait, where you've got a localized issue facing the hip pain, knee pain, ankle pain, sciatica, these kind of things. You might have a high step gait. So this is where they raise the knee, usually unilateral, where they raise the knee much higher than on the other side, and that's because what they can't do in a high step gait is because they're not able to dorsiflex, so they're not able to actually bring the ankle up like so as to do the heel strike, because that's what happens. We do heel strike, mid-foot, ball of the foot. It's a 3-point pivot motion is gait. And the reason they can't do that is because the muscles that innervate part of the musculature group, the muscle group that innervates the muscles to actually do dorsiflexion, is actually dysfunctional, and that's because you may well have common peroneal nerve palsy. This is foot drop. So the common peroneal nerve, remember, runs around the head of the fibula, and any localized trauma, which is often seen in a hospital setting when we slide patients across beds, be it from a bed to a CT scanner or otherwise to the theatre table, etc. And the final one I want to mention here is, and there are a whole host of others, but the final one I want to mention in the context of neuro is a fenestrated shuffling gait. A fenestration or fenestrated shuffling gait is where the patient is kind of leaning forward, stooping forward, and the shuffle, so that the feet are actually shuffling, and then they're actually propelling forwards, and that's fenestrated gait, and that again is indicative of Parkinsonianism. Again, I mentioned the difference between Parkinson's and Parkinsonianism. I then get the patient to turn around and walk back to me. I get them to do heel to toe, because I'm assessing what we refer to as tandem gait, and here what I'm doing is essentially assessing their coordination balance, again basal ganglia, cerebellum. I ask the patient to lay down, and then I'll start with the cerebellum. So again, neurological examination, I do it in 3 parts. I do the central nervous system for the most part of it initially, so your cerebellar dysfunction, etc. assessment first, coordination, etc. Followed by then the muscular components, so your myotomes, DTRs, your tendon reflexes, and your tone, followed then by the spinothalamic tract, and then your dorsal column, medium lemniscus. That's the way I do it, and the modalities that are essentially dictated by. So in terms of laying the patient on their back, again 45 degrees, dysthychokinesia, the way to assess that is I ask the patient, as I lay there, I'll stand on the end of the bed, I'll place my hand just in front of their foot, and I'll ask them just to tap like that with the foot repeatedly, and that is equivalent to this concept what we did on the hands. And again, you'll do both feet. That's looking for dysthychokinesia. And then I'll ask them to lift the heel, the heel, and then I'll ask them to slide it down the shin and then in a vertical axis like so 4 or 5 times, and then do the same on the other side, and there's a coordination. Moving on from that, I'll then actually move on and assess their tone. Now, in the medical setting, clinical conventional medics, in the A&E and GP setting, in terms of the hip, what I've seen patients do is just roll the hip, which is fine. As an osteopath background, I actually take up the hip into flexion extension and then circumductory motion one at a time. And then with the knee, what the medics generally do is they just take the knee and they just lift it and let it fall. Again, given background, I take the knee into full flexion extension and I do an international rotation within reason as well. And then I'll move on to the ankle. Here I'll do passive dorsiflexion, ankle, plantar flexion, dorsiflexion. I'll do inversion, eversion, and a better circumductory motion. Remember, what we're looking for here is anything that's abnormal. So cogwheel rigidity. So I'll use the knee as an example. And with cogwheel rigidity, the equivalent of the elbow is where the knee actually does that, as you do that. Then the second one here I want to assess is lead pipe rigidity, which is a common one again, and it's essentially the whole thing moves smoothly, but it's very resistive all the way through, as if you're bending a lead pipe. Both of these indicate Parkinsonianism. The next one is clasp knife rigidity, where there's initial resistance and then there's a give, and everything happens just as normal without any resistance, and that's indicative of an upper motor neuron lesion. Once I've assessed the tone, I'll then go on to your muscle power testing. Again, I'm not going to go through the myotones here. I think you all well know that. The reminder here is assessing on a scale of 0 to 5, the MRC scale for muscle power testing. Moving on from there onto the deep tendon reflexes, of which there are 2 in the lower extremity. Your knee, so your patellar tendon, that's your L3, 4, and then your S1, which is over your Achilles tendon. Polite reminder here. Deep tendon reflexes assess the neurological arc, the integrity of that arc local to that circuit. So it goes from the knee, sensory receptors, all that malarkey, into the dorsal horn, ventral horn, and then out to the quads. And that local circuit is what you're assessing. DTRs and Achilles tendon, common insertion point, not only for 2 but 3 muscles, the gastrocs, and then deeper to that soleus, and then deepest of the 3 is your plantaris. The deep tendon reflexes again are measured out of 4. 2 out of 4 is normal, 0 is absent, 1 is hypo reflexes, such as that seen in hypothyroidism, and then 3 out of 4 hyper reflexes, such as that seen in hyperthyroidism as an example, and then 4 is clonus. Clonus is repetitive rhythmic contractions in excess of 5. More than 10 is pathology that warrants investigation, but these references differ. Once we've done all of that, again, don't forget to mention with or without reinforcement so as to distract the patient, and all present and equal. All of the appendicular skeleton is bilateral, so there's good opportunity for us to be able to compare. In the context, once you've done the deep tendon reflexes, there's another reflex called the Babinski reflex. Now I mentioned there are 2, but this is the third, which is actually assessing not a local circuit, rather this assesses the corticospinal tract. Now we go around the base of the foot and we go from the outside inwards towards the ball of the foot on the hallux, the first metatarsophalangeal joint. And we do not note as Babinski being positive and negative. That's categorically incorrect. What we should note Babinski as being upgoing or downgoing. So in the normal circumstances, the hallux, the big toe, should flex, and as a patient withdraws their foot on the back of this actual stimulation. And that's a normal Babinski, that's a downgoing Babinski reflex. Whereas if the patient actually extends the hallux, then that's an upgoing Babinski reflex, which is indicative of a lesion in the corticospinal tract, an upper motor neuron lesion. Now remember, in children this is actually normal, and children, I mean by kind of between 6 to 18 months, okay, 6 months to 18 months is by which time the actual Babinski should actually develop, and therefore before that age group, so that anyone younger than kind of 6 to 18 months, and depends on the reference, hence the large range, it should actually be upgoing, after which it should become downgoing. Moving on from that onto your sensory testing, so then spinothalamic tract, and the modalities here are your sharp and dull, which is what you will generally assess, but you can also assess temperature if you're using a hot and cold object, and there's light pain here as well, amongst other modalities, and you'll go down the dermatome. So remember, L1 is in the groin, L2 on the anterolateral aspect of the thigh, L3 for around the knee, and then you go inwards, L3 for around the knee, and then L5 is your large toe, and L6 is your small toe as it comes up the side of the lower leg, innervating the sural nerve distribution. And so with the lower extremities, you go inwards and then outwards. Okay. And then finally, you finish off with your joint position sense and your vibration. So vibration, again, remember, we are going to use the frequency, lower frequency, so your 128 Hertz or your 256 Hertz. The 512 Hertz is used for Weber's and Rooney's tests in the context of cranial nerve examination for vestibulocochlear dysfunction. So you go, again, you can place the tuning fork right at the tip of the toe, and again ask the patient to report whether or not they feel that sensation, that vibration. And the joint position sense, again, remember to hold the joint from the sides, and as well as the actual hallux, that you're going to move from the sides rather than the AP regions, because the pressure receptors and everything is more prevalent here, so that will again influence and give you inaccurate results. And there you have it. So that order of kind of cerebellar, upper kind of central nervous system, followed then by your motor component, followed then by your sensory component, and the sensory component subdivided into your spinothalamic and dorsal column medial limb meniscus. Thank you for watching.